So my practice is different in that I practice functional medicine. I was trained in internal medicine. My practice clinic now is a functional medicine practice. So traditional medicine is more, at least in the United States, what I call the disease-drug model. Here's the disease, here's the drug. With functional medicine, we look for the root cause of the problem, look at how all the organ systems interrelate with each other, and try and use natural treatments whenever possible, avoiding medication. So traditional medicine is more the medicine of what do you have, and functional medicine is more the medicine of why do you have something. So I think it's important to talk about EDS patients because about 60% of EDS patients have digestive issues that's probably caused by SIBO or small intestinal bacterial overgrowth. So it's quite popular now with traditional doctors because this new drug that costs about $1,500 for one course of treatment, now it's popular. So we could talk for hours about just celiac disease and gluten sensitivity, which is another area of interest of mine, but at the end of the day, if you asked me what we did in our clinic, we seal and heal your gut. Leaky gut is kind of a slang diagnosis, but if you call it increased intestinal permeability, that sounds more scientific. We were talking earlier about this increased intestinal permeability, which if you talk to a traditional medical doctor in the States and you tell them, well, I deal a lot with leaky gut, they're going to think you're a quack. But if you were to go and Google increased intestinal permeability, you would find over 10,000 articles. It's just a different name for the same thing, a slang layman's term versus a more scientific term. So that is really the basis for treating anyone that we see in our clinic, is making sure that they don't have increased intestinal permeability. One of the causes of increased intestinal permeability is SIBO. So SIBO is not IBS. SIBO is one of the causes of irritable bowel syndrome or IBS. So even though you haven't heard of SIBO, you've heard of IBS or irritable bowel syndrome, just start thinking that a lot of those patients with that IBS diagnosis might have SIBO as the cause of their IBS symptoms. So if you, for example, if you have an ulcer, and it's caused by Helicobacter pylori, H. pylori, then you don't have H. pylori disease, you have an ulcer that's caused by H. pylori. So what happens with SIBO is you have a migration of colon bacteria up into the small intestine where they don't belong. And that's associated with altered defecation, altered bowel movements, either diarrhea on the one hand or constipation on the other hand, are the two alternating. So they are contrary, and that's, we get into SIBO, we can talk about why some have diarrhea and some have constipation, and then some alternate, or either one way or the other. And in the old days, going back when I first got interested in this 30 years ago, everybody thought these patients were just, stressed out. It was more of a psychological disorder than something actually going on in the gut. So that basically is SIBO. SIBO and IBS symptoms overlap. SIBO is a cause of IBS. And then we're going to get into what causes SIBO, because remember, functional medicine is the medicine of why. It's not why you have IBS, why you have SIBO. It's to keep trying to figure out why you have your symptoms, because if you can find the underlying cause, then you can actually treat the root cause of the problem. So what are the other symptoms of SIBO? We talked about the digestive symptoms, but there are a lot of other symptoms associated with SIBO. And so SIBO is one of the causes of leaky gut. And I know it gets a little bit complicated, but it's all, the names are not as important as just trying to figure out what's actually going on. Right. So SIBO is a cause of IBS, and SIBO is also a cause of increased intestinal permeability. So the other symptoms you can get with SIBO are outside the gastrointestinal tract. And if you've got increased intestinal permeability from whatever cause, then you can get systemic inflammation or inflammation in other parts of the body. So these patients might be diagnosed with fibromyalgia syndrome or chronic fatigue syndrome, and the problem's really starting in the gut. So that can also manifest with skin disorders, mood disorders, anxiety, depression. So the other thing that you can get is vitamin and mineral deficiencies because your digestive tract's not working. So here's the way that I like to explain it to our patients. So think of your body as a plant. And if you wanted to be the healthiest plant that you could be, it would be a function of what you eat, what you put in. And then the second thing that has to happen is the food that you put in has to be fermented. So you have to eat good food. It has to be fermented. Think of it this way. If you take cabbage and you ferment it, then you have sauerkraut. So the third thing that has to happen is you've got to get the nutrients from out of your small intestine into your bloodstream. If you think of the villi in the small intestine as like the roots of a plant, if that's damaged, if you have leaky gut, or the villi are damaged, like you see with celiac disease, then you're not able to get the nutrients out. So you're a plant, and so let's pretend you took a nice plant and you put it in a nice composted organic soil, but then you cut up the root system. So that's what we focus on in our clinic. Is we have 3 nutritionists. They will help you what to eat. We make sure that you've got the right probiotics. It's a little more involved than that, and then we try and do things to fix your root system. So I've been getting, just as an example, going back to, let's say, 1990, when I wrote my first book on irritable bowel syndrome. As part of the plan, we would put patients on an elimination diet, and part of the things that you would eliminate would be gluten, and that's when I came to discover that gluten is not really so good. So EDS is one of those things that where you have decreased intestinal motility, and if you have decreased small intestinal motility, then the bacteria can kind of migrate back up. So just assume that if you have an EDS patient, there's a high likelihood that they have digestive symptoms. And there are a lot of things that could be causing the digestive symptoms. It may be they're gluten sensitive. So we get everyone off gluten on their trial medicines. Or it could be SIBO. Now celiac disease, which is the worst form of gluten reaction, autoimmune disorder, is one of the causes of SIBO. So you can see how it's all sort of intertwined. So one would be an intolerance to fermented foods. We talked about fermentation and how it's good, but when patients that have SIBO eat sauerkraut, they do not do well. And they don't do well on foods that are easily fermented because they've got all these bacteria up here that are taking that food. They should be there to begin with, and they're taking that food and they're fermenting it and then causing even more gas. So we will ask our patients, do you tolerate sauerkraut? Do you tolerate any fermented foods, kombucha tea, things like that? The other clue is, since they have too many of these what would otherwise be good bacteria, they're just in the wrong place, that they will often have a temporary improvement when they take a course of antibiotics. So if you suspect someone has SIBO, the next question is, how do you make the diagnosis? So the gold standard for making the diagnosis is a breath test. So it's interesting, we were talking about how with IBS, a lot of those IBS patients have SIBO. If you have bacteria that produce hydrogen gas, you're more likely to have diarrhea. And it's a lot more complicated than that. If you have bacteria that produce hydrogen, you get diarrhea. If you have bacteria that produce methane, called methogens, then you're more likely to get constipation. There's a new test coming out that's going to measure hydrogen sulfide gas, so it'll actually be 3 gases. So that's the gold standard for diagnosing SIBO, is doing the breath test. So then now there's a more scientific term. It's called SIFO, SIFO, S-I-F-O, small intestinal fungal overgrowth. So at the end of the day, you want to treat the underlying motility disorder. You want to get them off medications that might make it worse, like acid blockers. You want to reestablish normal good bacteria in the gut. And that's a process of changing their diet initially to decrease foods that are easily fermentable because that can make you worse. So we have what we call a biphasic diet. They go on a diet at this part, and then as we do these other things, then they're able to eat. Fluoroquinolone antibiotics can cause tendon damage. So I think a lot of these people with EDS, if they take fluoroquinolones, that makes them worse. They've just added fuel to the fire. So I think all of these things are related in a lot of patients to fluoroquinolone toxicity, and that's the real story that we ought to be telling. If you have EDS patients, they should never take these quinolone antibiotics because it can make their underlying tendon problem worse. A. B. I think a lot of these people diagnosed with EDS have fluoroquinolone-associated disability syndrome. I think my brother, Susan's brother, my brother, who's been diagnosed with EDS, he has none of the clinical signs really, not enough clinical signs to diagnose him with EDS. And he's been on quinolones. And we see a lot of patients with SIBO that have been on quinolones. And we call them the bloaters. Their main symptom is bloating. And they will eat and they get this sudden bloating. They'll bring pictures in. And every one of them has been on quinolones. And quinolones can damage not only your connective tissue, but also your nervous system. And now quinolone toxicity has been associated with peripheral neuropathy.
Do you think that it's a selection of microbes or the chemical action of fluoroquinolone?
So I think the quinolones damage your connective tissue and damage your nervous system. So that's kind of my, but if you look at, and I think that SIBO is associated with quinolones. If you look at American soldiers coming back from the Iraq War, so a lot of them have SIBO and a lot of these other disorders, and they were given quinolones to prevent anthrax. So I mentioned Dr. Pimentel earlier, who's probably the world's leading SIBO expert, and he would contend the number one cause of SIBO is food poisoning. So my theory is it's not the infection that's causing the SIBO, it is the treatment, and the treatment is Cipro or quinolones. So last thing, if nothing else, if you treat EDS patients, if you were to do an internet search, put EDS quinolone antibiotics, and you'll see at least these patients should never be given quinolone antibiotics unless it's a life-threatening, no other choice.
When you are not sure,
Give quinolone and see what happens. Well, thank you very much. I know it was
Thank you very much. Thanks very much.
Any questions? Yes.
Est-ce que vous avez remarqué, vous allez faire la traduction, est-ce que vous avez remarqué chez vos patients une alternance avec le SIBO et anorexie, troubles alimentaires en général?
We see a lot of food intolerances and food sensitivities, not just with SIBO. My interest in IBS started, or irritable bowel syndrome started with an interest in food intolerances and food sensitivities. And a lot of these patients are so uncomfortable when they eat, they don't want to eat, and they do end up losing weight. So here's another thing. If you look at all these things that I mentioned, EDS, mast cell activation, POTS syndrome, and SIBO, it's twice as more common in females than men. And who's more likely? Is that for me?
Yep.
Thank you. So think about it, and this is part of my theory. I'm going to be writing a paper on this when I get back from the trip. But so women are more likely to get all four of these conditions. Women are more likely to get quinolones because women are more likely to get urinary tract infections. So as I mentioned, we're collecting a series of patients now. They're all female, and they all have this intense, sudden, painful bloating. So I guess we're kind of tuned into this whole quinolone thing. So we always ask everybody with any of these weird symptoms if you get a quinolone. So there seems to be a connection. Well, I want to thank you all. I want to thank Susan for inviting me, and I want to thank her and Mariana for hosting this, and I really want to thank them for spreading the cause about EDS, because it's a real problem.
Yes.
And having a center where people can come and get sort of a multidisciplinary approach for treatment is wonderful, but I think the first thing is increased disease recognition, and then if you figure it out, you got to figure out what to do for it. And so thank you, Susan, my favorite big sister.
I would like to make a comment.